let us just finally talk about the ANS, and that will be, we will have covered a lot of nervous system discussion. Autonomic nervous system. You see, basically our nervous system has got three branches: central nervous system, the CNS, which we have discussed, peripheral nerves. So CNS will have brain and spinal cord, then the peripheral nerves from spinal cord to the periphery, or in the other way around, and we have ANS, autonomic nervous system. If these two are called as somatic system, this is a somatic nervous system and this is autonomic nervous system. Under conscious control or reaching consciousness is the somatic nerves, whereas autonomic nervous system controls our involuntary functions. The ANS has two branches, as you all are aware: the sympathetic division and the parasympathetic division. Let's try to understand what the functions of these divisions are. These two divisions, they are supplying or innervating all the organ systems and controlling the automatic functions. Their functions are mostly contradictory, means sympathetic will increase the heart rate, parasympathetic will decrease the heart rate, but at some places the function may be complementary also to each other. Like if parasympathetic will increase the motility, then sphincter relaxation will be under sympathetic control. So complementary to each other, that's also there, but mostly at most places it is contradictory to each other. But if we have to see the clear-cut demarcation in their functions, then the parasympathetic division, it mainly controls our routine functions of the body. Minute to minute, moment to moment, and routine day-to-day life functions are controlled by the parasympathetic division. For example, we eat something and there is movements of the digestive tract, secretions by the glands, or our resting heart rate. When we are in the resting situation, resting heart rate is under parasympathetic control. It's a routine function. But then when the body is stimulated, body faces some kind of a stress, some kind of a challenge, then body is prepared to face that challenge by the sympathetic system. So that's the function of sympathetic system. It prepares the body for facing any challenge or stress, any physical, emotional stress. The body will have sympathetic system to prepare for that. That's a division of functions between these two. Where are they located and how do they function? So far as the sympathetic system is concerned, as I said, it will come into effect only when the body faces some kind of a stress or challenge. For instance, our resting heart rate will be under parasympathetic control, under the vagal control, but when we are performing exercise and body is facing the stress, then heart rate is increased by the sympathetic division. So let's see where sympathetic division is located. It is mainly called as the thoracolumbar outflow. Thoracolumbar outflow. You see, in the spinal cord segments, there is a gray matter, and the gray matter has anterior and posterior horns. In the thoracic and lumbar segments, there is this intermediolateral horn on either side, and this intermediolateral horn has nerve cell bodies for the sympathetic nerves. So sympathetic nerve will emerge from these nerve cell bodies and will come out. So that's the origin of the sympathetic nerves. Thoracolumbar outflow, and there are three cervical ganglia as well. And for these thoracic and lumbar segments, for each segment, as the sympathetic nerve comes out, it synapses in the ganglion. Ganglion is the relay station, and then the postganglionic nerve will go to the organs. That's a sympathetic division. Parasympathetic division is called as craniosacral outflow. Craniosacral outflow. So cranial nerves are parasympathetic in function, and sacral nerves means parasympathetic nerves arise from the sacral segments. All cranial nerves are not parasympathetic. The cranial nerves 3rd, 7th, 9th and 10th, these 4 cranial nerves perform parasympathetic function. The remaining cranial nerves are somatic, like movements of the eyeballs, movements of the tongues. They perform all the somatic functions. These 4 cranial nerves perform the parasympathetic function, and the most important one, of course, is vagus, 10th cranial nerve, because it starts from the cranial cavity, it goes into thoracic cavity, controls the heart function, it goes into the abdominal cavity. So that's cranial nerves, the parasympathetic function performed by these 4 nerves, and sacral segments also give rise to the parasympathetic nerve. Now, if you see the difference between the sympathetic and parasympathetic nerves, note this fact that the sympathetic nerves, as they come out of the spinal cord through the anterior horn, they immediately synapse in the ganglion. Ganglion is located just outside the spinal cord, and then the postganglionic nerve will travel to the organ. So the point that I am making is, preganglionic nerve is short and postganglionic nerve is long. So far as the parasympathetic nerve is concerned, it is other way around. In the case of parasympathetic nerve, the preganglionic nerve is long and the ganglion is located near the organ or sometimes in the wall of the organ. So postganglionic nerve is very short. In fact, postganglionic neuron does not have any axon to it, no nerve fiber. So postganglionic parasympathetic neuron is called as anaxonal neuron. It does not have an axon. But that's a difference between sympathetic and parasympathetic divisions. Ganglion being the relay station, and the preganglionic and postganglionic nerves, whether long or short, this is a difference. Now let us see the neurotransmitters involved. Now first of all the preganglionic nerves are cholinergic, whether sympathetic or parasympathetic. Preganglionic nerves are cholinergic. So ganglionic transmission is by acetylcholine. Parasympathetic postganglionic nerve is also cholinergic. So final neurotransmitter released on the organ is acetylcholine. Sympathetic postganglionic nerve is adrenergic. That is, it secretes noradrenaline at its nerve ending. So final neurotransmitter released on the organ is the noradrenaline. These are adrenergic nerves or noradrenergic nerves, but ganglionic transmission is cholinergic for both sympathetic and parasympathetic. So far as the receptors are concerned, well, just remember one thing: tyrosine is going to form these noradrenaline and adrenaline. Tyrosine forms L-dopa, then dopamine, and then noradrenaline and adrenaline. Now conversion of noradrenaline to adrenaline needs the enzyme which is not present in these postganglionic sympathetic nerves. So they mainly release noradrenaline, whereas the converting enzyme is present in the adrenal medulla gland. So major secretion of the adrenal medulla gland would be adrenaline. That's the catecholamines released by sympathetic nerves and adrenal medulla gland. The nerves mainly secrete noradrenaline. as the neurotransmitter. Now, so far as the receptors are concerned, acetylcholine has two types of receptors, muscarinic and nicotinic receptors. Nicotinic receptors are of two types, N1 and N2. Where are these receptors present? Well, nicotinic transmission, nicotinic acetylcholine receptors, and that transmission is present at the three places: neuromuscular junction, nicotinic receptor for acetylcholine, ganglia, means all the ganglionic transmission, whether sympathetic or parasympathetic, we have seen its cholinergic transmission. So it's nicotinic receptors in the postganglionic neuronal membrane and in the CNS neurons. These three places have nicotinic receptors. And the organ systems have muscarinic receptors. The organ systems, there are 5 types of muscarinic receptors: M1, M2, M3, M4 and M5. M3, M4, M5, they mediate the excitatory effects of acetylcholine. So you will see that these receptors are present in the digestive tract, in the glands, and they have an excitatory effect of acetylcholine. Whereas M2 muscarinic receptors are present in the heart. So vagus inhibits the heart. The acetylcholine has inhibitory effect on the heart via the other type of muscarinic receptor, the M2 muscarinic receptor. That's how acetylcholine is excitatory somewhere and inhibitory somewhere, depending on which receptor present where. So M2 receptor in the heart, so acetylcholine mediates the inhibitory effect of acetylcholine, inhibitory effects via the receptor. Sympathetic nerves, the adrenaline and noradrenaline, they have two types of receptors, alpha and beta, and in that too there are subtypes, alpha 1, alpha 2, and then beta receptors have beta 1, beta 2, beta 3. These are the receptors for adrenaline and noradrenaline. You see, again, adrenaline mediates its excitatory effects via beta 1 receptors. Adrenaline stimulates the heart because heart will have beta 1 receptors. But inhibitory effects of adrenaline are mediated via beta 2 receptors. So where do you find them? At two places, important places where you see beta 2 receptors which mediate the inhibitory effects of adrenaline. Adrenaline, its excitatory effect via beta 1 receptor. So heart, you know, excitation of the heart under sympathetic control and adrenaline. But beta 2 receptors are present in the bronchi, smooth muscle of the bronchial walls, and skeletal muscle blood vessels. The skeletal muscle blood vessels in their wall have smooth muscle, and this smooth muscle will have beta 2 receptor and bronchial smooth muscle. So therefore, if a stimulation of the sympathetic nerves, elsewhere there are alpha 1 receptors in the vessels, so there would be vasoconstriction, excitatory effects of adrenaline. But in the skeletal muscle there are beta receptors, and therefore there would be skeletal muscle vasodilation. Skeletal muscle will show vasodilation. This you can understand, for instance, very important during exercise. When a person is performing exercise, the skeletal muscle needs an increased blood flow. So skeletal muscle should have vasodilation. So this blood vessel in its wall has the smooth muscle. That smooth muscle has this beta 2 receptor, and therefore it will cause relaxation of the smooth muscle, and the blood vessel will dilate. Blood flow will increase. Whereas alpha 1 receptors elsewhere have caused vasoconstriction. So there the vessels have constricted and the blood flow was diverted, and more blood flow was brought into the skeletal muscle. So excitatory effects inhibitory effects mediated via different types of receptors. And in the bronchial walls, in the walls of the airways, these smooth muscles have this beta receptors, and therefore they will mediate the relaxation and bronchodilation. So you see specific beta stimulants like salbutamol, they cause bronchodilation by acting via these beta receptors in the bronchial walls, the smooth muscles rather. Smooth muscle present in the airways having the beta receptors, when they are stimulated by the catecholamines, there would be bronchodilation. So excitatory effects, inhibitory effects. Just one more receptor which we can mention, alpha 2 receptor. Alpha 2 receptor is a presynaptic receptor, presynaptic autoreceptor it's called. That is, once the noradrenaline is released, then further release of noradrenaline from the presynaptic ending is augmented or attenuated by this alpha 2 presynaptic receptor. Remember, there are postsynaptic receptors for exerting the effect of noradrenaline, but whether further noradrenaline is secreted or not and how much, that depends on this alpha 2 presynaptic receptor. So noradrenaline will combine with this alpha 2 presynaptic receptor called as autoreceptor. It will further modulate the secretion of noradrenaline from the presynaptic terminal. These are the receptors that mediate. So let's just try to understand various organ systems and the effects of sympathetic and parasympathetic nerves. For example, pupils. Pupils constricted or dilated. You see, the iris has two types of muscle, the circular muscle of the iris and radial muscle of the iris. Circular muscle of the iris is under parasympathetic control. That is the third nerve. And when it contracts, there will be pupillary constriction. Whereas the radial muscle of the iris is under sympathetic control. So sympathetic stimulation will cause contraction of the radial muscle of the iris, and the pupillary aperture will increase in diameter. Pupils will dilate. Pupillary dilatation is called as mydriasis, and pupillary constriction under parasympathetic control is by meiosis. So that's how sympathetic and parasympathetic have contradictory effect. Well, I also said about the heart. Resting heart rate is under parasympathetic control, but sympathetic nerves, they will increase the heart rate whenever body faces some kind of a physical, emotional stress or turbulence, challenge. That was the ANS. Finally, we'll finish this discussion on CNS by just asking one MCQ on the cerebrospinal fluid. You know, cerebrospinal fluid performs very important functions, the CSF, like it works like a cushion to the brain. It has exchange of nutrients and gases between brain and the CSF occurs. So let's have just last MCQ. The normal CSF pressure in the left lateral recumbent posture is. Now mark this MCQ, it's a very interesting one. The options are 130, 130, 130 mm of water, 130 cm of water, 130 mm of Hg, or 130 drops. Look at the units carefully before you jump to any conclusion. I'm sure you're thinking of this B as the answer, but no. Always look at the units before you proceed with such an MCQ. Try to understand this. 1 mm of Hg is 1.36 centimeters of water. So if you're saying 130 centimeters of water, it would mean 100 mm of Hg. You think CSF pressure will be 100 mm of Hg, even more than the cerebral artery pressure? No. So now you got the answer. answer is 130 mm of water, which is same as 13 centimeters of water, which is same as 10 mm of Hg in the recumbent posture. 130 mm of water will be same as 13 centimeters of water, and 13 centimeters of water is 10 mm of Hg. So please always remember this conversion units. 1 mm of Hg is 1.36 centimeters of water, and this is the CSF pressure in recumbent posture, supine posture. In the seated posture, it will be 10 plus 10, that's 20 mm of Hg. In the seated posture, CSF pressure increases because of the pressure of the cerebral contents on the meninges, and CSF reabsorption rate decreases, and therefore CSF pressure increases. It will be 20 mm of Hg, or 130 plus 130, 260 millimeters of water, that is 26 centimeters of water, or 20 mm of Hg. What is your opinion about this last unit, 130 drops of, this is the drops of CSF on lumbar puncture. This drops is drops of CSF on lumbar puncture. If you see the procedure, when the LP needle is inserted, the drops start coming out, the CSF drops coming out. So how many drops per minute? That gives a crude indicator of CSF pressure. It should not be more than 1 drop per second or 60 drops per minute. If the CSF pressure has increased, the number of drops coming out of LP needle, lumbar puncture needle, will also increase. That's an indicator of an increased CSF pressure. So remember these units, remember the CSF pressure in different units, and that's how you always think of units when such MCQs are asked. That's the entire discussion on CNS.